Dear colleagues, during this last month, we have been holding various educational initiatives. This is the second event that we're performing in regards to corneal disease, and the session will be chaired by by specialists from Armenia and abroad. So, from the Armenian side, Anna Hovakimian will be the chair from the Armenia. She's the head of the Department of Inflammatory Diseases at the Ophthalmological Center of Malayan, and she's an associate professor of ophthalmology in Yemen State Medical University. From the U.S., John Havanisyan joined us. He's the vice president of the Armenian Eye Care Project. He's a faculty member of Julius Stein Institute, and he's in the UCLA. He's an associate professor from there, and Matthew Witt is from the Irvine University, California. He's the professor of the eye diseases. He's the head of the military department, and residents from our departments will be presenting clinical cases that were organized by their heads of the departments, and we'll hold some discussions. And I'm sure that during these discussions, we'll have some productive discussions. You can mention your questions in Q&A section of the Zoom. And now I would like to invite Anna to continue. Hello, dear colleagues. Thank you for joining us. Thank you that you joined us. As Dr. Yezen already mentioned, today the Eye Care Project, and together with Malayan Center, this is the second seminar organized by the Inflammatory Disease Department, and we have very interesting clinical cases, and our residents will be presenting Mane Shahinian and Shania Premian. And I would like to ask Mane to continue from here.
Good evening, dear colleagues. First of all, I would like to thank Armenian Eye Care Project for this great opportunity. I'm a third-year resident at Malayan Ophthalmological Center, and today I would like to present an interesting, challenging case about visual recovery after Boston Type 1 K-Pro procedure in monocular patient with a prephthalmic eye. Quick review about the keratoprosthesis. Developed at Massachusetts Eye and Ear Infirmary, is the most widely used keratoprosthesis to date. It comes in two types, type 1 and type 2. Both are made from color button-shaped polymethyl methacrylate and titanium. Today we are going to talk about type 1 keratoprosthesis. Shortly about the statistics, unfortunately, there is not much data. Here you can see the numbers given from the Eye Bank Association of America, number of the tissues supplied during the past 5 years. So the indications, what are the indications to do such challenging surgery? The main indications are 2 or more failed grafts, limbal stem cell deficiency, which can occur due to ocular burns, chemical injuries, autoimmune diseases such as Stevens-Johnson syndrome, mucous membrane pemphigoid, and also indication is visual acuity of 20/200 or less. So the main postoperative management includes, first of all, antibiotics, a short course of oral antibiotics and topical antibiotics. And the key point is these patients are suggested to be under daily topical antibiotics forever, a lifetime. And post-operative management also includes topical corticosteroids, soft contact lens use, and glaucoma management. So which are the complications? The K-Pro procedure is already challenging because these eyes are already complicated, and the post-operative period is also very important. The most common complication is retroprosthetic membrane formation, glaucoma, endophthalmitis. These patients are a lifelong risk of death. Corneal melt, infectious keratitis, posterior segment complications, and also class K-Pro loss, extrusion and K-Pro loss. Shortly about our experience, since 2006, K-Pro surgery has been performed also in Armenia at Malayan Eye Center in Cornea Uveitis department by Dr. Hovakimian. So far, around 30 surgeries were performed, and our cases are mainly the patients with chemical injuries. And now we can discuss our interesting case. So, 72-year-old female presented to Malayan Eye Center. She was monocular with a history of diabetes mellitus type 2. Her main complaints were tearing, redness, pain, blurred vision, photophobia that occurred after cataract surgery. The slit lamp examination, as you can see on the picture, showed an epithelial defect. The sensation of the cornea was down, so neurotrophic ulcer was diagnosed. A PCR was also performed, which came negative for HCV 1, 2, and VZV viruses. The treatment started immediately, which include serum tears, artificial tears, oral doxycycline, fluorometholone, and tetracycline ointment twice a day. Unfortunately, 2 weeks later, the patient again presented, this time with hypopyon, enlarged epithelial defect, and mild stromal infiltrate. We started immediately an antibiotic therapy and also did a scraping because secondary bacterial infection was in our minds. The laboratory results showed Neisseria sicca. It was found this pathogen. Unfortunately, we didn't have much information, and literature described only a few cases with this pathogen that can cause conjunctivitis, but in our knowledge, we didn't know any exposure to the cornea by this pathogen. And we started antibiotic therapy, and we added moxifloxacin, cyclophilic agents, tetracycline ointment, and also amoxicillin per oral because of the sensitivity of the pathogen. As you can see here, the condition of the eye got worsened. We can see the dense stromal infiltrate, the symblepharon occurred. We can see mild perforations, bleeding, and despite the treatment, which also included amniotic membrane, it didn't help. And because the infiltrate got already near the limbus, there was a big risk that it could go further to the sclera and the patient could lose her only eye. And that's why Dr. Hovakimian made a decision to do penetrating keratoplasty surgery just to save the only eye of the patient. As you can see, after just 1 week after the surgery, another trophic ulcer occurred on this time on corneal transplant. It got infected, but however, immediate TAR therapy was performed. In the pictures, you can see in the first picture that the cornea transplant got infiltrated, the sutures got loose, and we immediately started again the antibiotic therapy. However, 10 weeks later, we can see that the eye got, after the treatment, a little bit white. The scars occurred, and probably due to melting, loose sutures, and also the patient developed ciliochoroidal detachment. Because all of these, the eye started to shrink. And I forgot to mention that the patient was also on atropine eye drops because of the ciliochoroidal detachment. And finally, in the picture below, you can see that the eye ended up with dense scarring and subatrophy. So here you can see the B scan, which can clearly show the ciliochoroidal detachment. And what do we have? Before capo surgery, this is the condition of the eye. The visual acuity was light perception. The axial length of the eyeball was 70 millimeter. Initially, it was 23. The IOP was 5 by Goldman and 11 by Maklakov. So after the discussion with Dr. Aldave, there was made a decision to do an intravitreal injection in order to keep the turgor of the eye to make it firmer. So after this, upon the request of Dr. Hovakimian, Dr. Vardanyan did the intravitreal injection with Hyalon 5 viscoelastic. And we can see the next day, the IOP increased to 70 by Goldman and 23 by McLachlan this time. And the eyeball became more firm, and finally it was possible to perform keratoprosthesis surgery of K-Pro. Fortunately, 4 weeks later, Dr. Aldave visited Malayan Eye Center, and he brought with himself the K-Pro device, and Dr. Hovakimian was able to perform the surgery. And you can see the result on the picture. Also, you can see the post-operative management, which included doxycycline per oral, the eye drops, and also soft contact lens use. However, 6 months later, on her routine visit, when patient presented with this time with severe conjunctival sclerosis, we can see that symblepharence occurred, and also the shortening or the fornix we can see on the first picture. And again, she was put back on the doxycycline per oral, and also eye drops were added, which were containing vitamin A and E. Artificial tears were added as well, and also mild steroids like fluoromethanol 3 times a day. With this treatment, the condition of the eye got better. However, this condition occurred several times, and every time she was back on the same treatment, and the eye was getting better every time. We'd like to say that the patient is very happy because she can do her daily routine. She can just walk, sleep, eat, and do her daily basis things. And because this was her last chance to regain some vision. And here are some questions for the discussion. The first question is, what would you have done differently in any of the stages of the care of this patient? The second question is, would you consider this patient to be the candidate for Boston type 2 because she had conjunctival sclerosis, symblepharence, bad eyelid function and tear function? And the third question is, we consider maybe we assume that she could have another some disease, but because of the lack of the lab test in Armenia, we can't do lab tests for vitamin A deficiency and mucous membrane pemphigoid. So we would like to ask you, maybe your experience can tell just by looking at this eye, could this be mucous membrane pemphigoid or vitamin A deficiency?
Before going to discussion.
Yes, and before going to discussion, we'd like to also present very briefly another case that occurred just recently. It's a 53-year-old male that with previous history of chemical injury. He came from Russian Federation, where he got his primary treatment and was recommended to undergo evisceration. However, he refused and came to Armenia. He was presented with visual acuity of light perception. And at first, in department of oculoplasty, an ocular surface reconstruction was done by Dr. Armine Harakeshishan. And after that, Dr. Hovakimian, here you can see the result after the eyelid reconstruction. After that, Dr. Hovakimian was able to perform 7 months later K-Pro surgery. In the first picture, you can see the fibrovascular lesion covering the eye. And then you can see the final result, the K-Pro. The patient vision now is 20/100, and he's under our control. Thank you. Oh, sorry.
This
is the final result of the eye. And that's all. Thank you. And we can go back to discussion. And I'm sorry, I just forgot to mention the visual acuity of this patient. The first patient got
2500.
2500, I'm sorry. Yeah, and she's stable. And the IOP is also stable.
Dear US colleagues, would you please add your comments on this case? What would you have done differently in any of the stages of the care of this patient? And would you really consider her to be type 2 candidate? John, Matt?
So to be perfectly honest, I am not an expert in these types of procedures. I think you've done far more of this than I have. So I don't know if I have any additional comments to add to this, but it's a difficult surgery, but even more difficult is the care post-op, depending on how the ocular surface reacts or goes with time. But what are your thoughts? Have you done many type 2s, and would you consider this to be a type 2 candidate?
Question is to me or to John? To me? No, we have no experience with Boston type 2 keratoprosthesis. Our experience is with just Boston type 1. And I would like to mention that the idea of injecting Helon-5 came from Coronet, where one of the doctors suggested that whenever the eye becomes tisical, subatrophic, you can inject Helon-5 every 6 weeks in order to keep the turgor of the eye. Dr. Aldave was suggesting to inject silicone oil, but we decided to go with Helon-5, and actually it worked. And I was expecting that after K-Pro procedure, if the reason was ciliary dysfunction, we will again have lowering of intraocular pressure. But thanks God, it stayed stable. Just one injection was enough. And I think the eye was also leaking, probably due to melting of the tissue, loose sutures, and the ciliochoroidal detachment altogether. So we are happy that we have this result. But as far as she's getting often xerosis and the symblepharon, I was just thinking maybe for her it's better to have type 2 keratoprosthesis. So
yeah, it could be. I'm not sure. It's a good question.
Okay, thank you.
How long has the patient had this prosthesis?
She's having this already more than 1.5 years already.
Okay.
Still
And
stable.
so the pressure, everything else is stable despite just that one injection of Helon?
Yes, she's just with this tarsography, but despite all this, she's able to move her eye right and left, and through her nasal aperture, she's able to, handle herself, do her daily things she needs to do at her home. So she's happy, we're happy. We're just concerned that how long this is going to stay stable, but it's already 1.5 years she's stable. So thank you so much. Hopefully she stays like that, like this. And we can't check vitamin A deficiency. She has diabetes. She may have liver dysfunction, but unfortunately, the labs are lacking this test, so we're just not able to check it. Thank you. And if we don't have questions, I think we'll kindly ask Shant Yepremian to go ahead with his presentation, please. Thank you.
Great presentations, by the way.
Thank you.
Thanks.
Good evening and good morning, depending on whether you're in the West or East Hemisphere. I'm Shant Yepremian, a third-year ophthalmology resident, and thank you for making me part of the team, and thank you for the opportunity to present this topic. Today, I'm going to talk about corneal immune ring, and I'm also going to present a case report. I'm going to present a case. A patient, 35-year-old male, presented to Malayan Eye Center from one of Russia's leading ophthalmological clinics, and his chief complaints were blurred vision, pain, redness, photophobia, and foreign body sensation in his left eye. His visual acuity was 20/100, 0.1. And everything started right after he got dust in his eye, and he was diagnosed with unknown keratitis in Russia. And he received some treatment, but without any improvement. On the slit lamp exam, you can see in the picture, we see a conjunctival, deep, and superficial episcleral injection. Also, we see paracentral corneal infiltrate, also 360 infiltrate in the periphery of the cornea. Let's take a pause on the case and talk about the stromal ring infiltrate, which is also known as Wesley ring. It is a non-infectious stromal infiltrate, which is the response of a infectious or a non-infectious antigens or foreign bodies, including microorganisms. It appears as stromal annular infiltrate, whitish to gray color, and it is located in the mid-periphery. Although there is no information about its incidence and prevalence, it is well known that it appears in non-infectious or also in infectious inflammatory conditions. Let's do a quick history review. First time in 1911, German ophthalmologist Wesley first described a reaction to a horse serum protein in the stroma of rabbit cornea. He described this ring infiltrate, and after that, it was called as Wesley phenomena, which could be. They managed to get it every time when they injected the same antigens into the cornea, so it was reproducible, and it was believed that it's an allergic reaction, so it called anaphylactic interstitial keratitis. This is just the beginning of the history. Let's limit ourselves with this one. Okay, let's talk about the mechanism. How Wesley rings is formed. The main mechanism is the complement activation, which eventually leads to the cell destruction. It is proven that complement can be activated in the cornea by its classical and alternative pathways. But what's eventually the mechanism that leads to complement activation? There are two possible hypothetical mechanisms in Wesley ring. Well, first one is the loss of complement inhibition. Bacterial products and other virulence factors, including antigens and phospholipases, can slough off the complement regulatory proteins from the cell membrane, which eventually leads to the cell destruction. And their job of this regulatory proteins is to protect the cell from complement 3 and also membrane attack complexes. The next mechanism is complement cascade activation by a migration of these antibodies from systemic circulation to the cornea. They enter via limbal vasculature, and they start to make complexes in the cornea, which eventually leads to activation of complement system and also leads to migration of neutrophils, which then develops. After that, the ring develops. And this is one of the reasons that we see the ring in the mid-periphery. Also, due to this, we can say, and there are also some studies that shown that complement is different in activity compared periphery to the center of the cornea. In the periphery, it is more active than in the center of the cornea. Etiology. It varies in etiology. It can have infectious and non-infectious causes. You can see the infectious causes listed down below, and non-infectious causes are contact lens, can be contact lens, foreign bodies, ophthalmic procedures. For example, corneal cross-linking. There is one study where they showed patient who got corneal cross-linking in an epi-off way, they can develop Wesley ring. But patient who had corneal cross-linking in an epi-on way, they didn't. So they concluded that the mechanism of Wesley ring formation, it is the epithelial damage itself. Also, other different surgeries can cause Wesley ring formation. The other non-infectious cause are drugs. Different type of drugs. One of the most common class of drugs are NSAIDs. Just because the topical NSAIDs, they just block cyclooxygenase without limiting the lipoxygenase pathway. They due to active lipoxygenase pathway, leukotrienes accumulate in the eye and they lead to neutrophilic migration because leukotrienes are very potent neutrophil chemoattractant. Diagnosis. There is no specific diagnostic criteria for Wesley ring, but the main key concept that all of us should remember is just to differentiate if it's infectious or not infectious, because the treatment is very different. So our diagnosis is based on history, presentation, and tests, PCR, culture biopsy to rule out or to find the infectious cause. Treatment. If the cause is infectious, you have to treat the underlying infection. If it is non-infectious, corticosteroids, they do great job in the treatment for the treatment. Yeah. Let's go back to the case. We stopped where we talked about the 365 corneal infiltrate peripheral, and what was our plan? Discontinue the treatment for 24 hours, and we will see the patient after 24 hours to do the PCR and culture to rule out any infection causes. And the patient was receiving only artificial eye drops after that. After 24 hours, we see a marked improvement in his eye. You see the improvement in the Wesley ring. Also, you see reduced redness in his eye. After thorough ocular history, we found out that he had been treated with multiple eye drops, including NSAIDs, antibiotics, and others. He was receiving every 15 minutes. So based on this, and this is the paper from his clinic from Russia, where you can see listed all the medications in the down part. So our diagnosis was based on his presentation and based on the improvement in 24 hours. Our diagnosis was drug-induced keratopathy with scleritis. We started the treatment with artificial tears 4 times, serum tears every 2 hours, chloromethylone twice, doxycycline 100 milligrams twice, tetracycline ornament 3 times, tobramycin antibiotic 3 times, cyclopentolate 4 times, and ibuprofen 400 for scleritis 3 times daily. 1 week later, unexpected worsening of his eye. We saw unexpected worsening. We saw an epithelial defect, and we think it was because of the toxicity of systemic ibuprofen, and The plan was stop ibuprofen immediately. Amniotic membrane transplantation was performed. Also, we added insulin eye drops and vitamin C, 500 milligram, twice daily. After 1 month, you see marked improvement here, but you can see the haze in his cornea, and also in the inferior periphery, you can see corneal neovascularization. So he received a subconjunctival anti-VEGF injection for his neovascularization, and also we added dexamethasone for haze. 4 times daily. And 90 days after, and this picture, we took it today because he had his visit today. You can see the haze in the cornea. And as he was planning to leave Armenia for quite a time, and we asked him to return in 3 months to check his eye. This was his final treatment. For the last 3 months, artificial tears 4 times, dexamethasone 3 times, timolol once for prophylaxis, tetracycline ointment 3 times, and vitamin C 500 milligram twice daily. Let's do a quick recap. Wesley ring is a non-infectious stromal infiltrate. Which is the reaction to the infectious or non-infectious antigens. And there is no diagnostic criteria. The main thing you have to do is to differentiate from infectious or non-infectious causes. And if you are not sure if it is infectious or not, you have to treat as infectious until proven otherwise. Thank you for your attention.
Thank you. And do we have questions?
Yeah. Our question is, what's your opinion about this case and what you've done different in this situation? Thank you.
Matt?
So I'm going to turn that back on you a little bit. What do you think is the the causative agent for that drug
I forgot to mention he received NSAIDs for every 15 minutes for probably a week or 2. NSAID eye drops every 15 minutes.
Like toxicity?
Yeah, and the toxicity. And because, as I mentioned, NSAID eye drops, they keep the lipoxygenase pathway active. It by itself can cause the migration of neutrophils, which eventually can lead to ring formation, but also toxicity, but drug itself can cause toxicity.
Okay, and why do you think he got worse after the initial? So my understanding, you stopped everything and you got a lot better, and then things took a turn for the worse. What is your thought about that?
The ring improved markedly, but the epithelium in the paracentral infiltrate, the part where he had the paracentral infiltrate, it got worse. We think that it may be ibuprofen.
Due to systemic ibuprofen.
Yeah, systemic ibuprofen, because he was receiving ibuprofen for his scleritis, and maybe that was also toxic for his cornea, but I don't know.
We assume that it may be due to systemic ibuprofen, no other idea. But the scleritis really improved because he was complaining of severe pain during nighttime. As the pain was gone, we just stopped it. But what's your idea why he got it? We don't know.
No, it's hard to say without being there and seeing the patient. But I don't think I've seen a case where systemic NSAIDs have caused that. But I certainly don't have as much experience as my uveitis colleagues on some of those things. But yeah, it's a very interesting case. What? So now you've sent him away on the steroid drops. Is that just to attenuate the scarring he has there, or do you think there's still active inflammation?
No, because of the scarring. He received.
He got total
Yeah.
epithelialization, so it's safe to go ahead with topical steroids. And yes, it's given for less scar formation, right?
He doesn't have any active inflammation.
It's 90 days
Awesome.
and we let him to go to Russia because he was visiting.
Yeah, I think this is a great case because it shows, you know, I'm always a little bit surprised when something is drug related, something that we've caused, right? So, or another doctor has caused. But it's definitely, the medications we give can cut both ways.
And we rarely see cases that we call anesthetic abuse keratopathy, where the patients who have had like a foreign body removed from cornea, and they just walk through to the drugstore saying, I have pain, tetracaine is given, and they can drop it every 15 minutes, every 30 minutes, and then show up with, anesthetic abuse keratopathy. So this is not common, but it happens like a couple of cases per year. So the toxicity is always an issue.
Can someone buy tetracaine there just without a prescription?
Yes, unfortunately, yes.
Gotcha. Okay. Yes, I've had a case of that as well. Although in my case, the patient stole the drop from our clinic, and that's where the problem happened.
Yeah, I guess we need to tell Ian that she's unmuted. She's muted.
Your colleague.
Unmute yourself. We don't hear
Oh,
you.
Dr. Chuang? Yep, I think she's getting set up and ready to go here.
Hi.
Hi, nice to see you.
So I will introduce
All right,
Dr. Chuang. Dr.
sure.
Chuang is one of our Cornea fellows this year. She's just about to finish her fellowship. She's an excellent doctor, and she's going to show you an interesting case.
So for the presentation today, I'm going to be talking about prosthetic iris implants, and then a little bit about like methods to repair iris defects. So thank you so much for the AECP and to Dr. Wade for the opportunity to give this presentation. So I'll kind of jump right into it. So we're all familiar with iris defects. We want to avoid any iatrogenic ones that can be caused through surgery. There are a variety of congenital and acquired iris defects. Either patients can have a complete aniridia congenitally or acquired. They can have colobomas, iris atrophy from trauma, and that causes a variety of symptoms, including photophobia, glare, decreased vision, and poor cosmesis. There are multiple methods of iris repair depending on the degree of the defect. So this includes cornea tattoo, which is shown, and they all have kind of their pros and cons. This includes cornea tattoo, which is shown here. So this pigment is deposited into the cornea. There is a risk of infection, inflammation. It is usually temporary and may need to be repeated. Another option for more extensive defects are colored contact lenses. So cosmesis is okay with these, but there are risks of infection. Some patients may not be dexterous enough to use colored contact lenses. And then surgically, there is iris reconstruction, so typically suture repair, the picture that's shown here. And then lastly, there's prosthetic iris devices. And so throughout the years, multiple devices have been developed. So these are some of the earlier models. So these are iris lens diaphragms and endocapsular tension rings with fins, shown here. And kind of looking at these in the eye, you can tell they probably do a good job of the visual symptoms. They block out the light where it's not supposed to be entering the eye, can help with photophobia, but cosmetically it's not not a great option. And so these are some examples of the iris lens diaphragm, the capsule tension ring with the fin that shows how they work. And then this is another iris lens diaphragm called Optic Model 311, which I guess is the most customized we've had up until now. So there's 3 color options depending on the patient's eye color, but still cosmetically is very noticeable. This is another example of that iris lens diaphragm. And so that brings us up to now, at least in the US, the first custom iris prosthesis was approved by the FDA back in 2018. It's composed of a silicone elastomer and can have fiber backing, which we'll go into later. So these, as you can see from the picture, are much improved cosmetically. They're actually hand painted. We send in printed photographs of the patient's eye that the patient has to sign off on, and then the company will produce the implant, and it's hand painted custom for that patient. And so in certain situations where the defect is kind of too extensive to be repaired surgically, and the tattooing, the contact lens are not viable options for the patient, we now have this new implant that can be used. So in this patient, they have a really large iridodialysis there. There's an attempted suture repair, but still quite a large defect. And then after sulcus fixation of the iris implant, it looks like cosmetically much better. If there was inflammation caused by that suture, hopefully that would be easier to treat after that suture's been removed. This is another example. So this patient with complete aniridia on the right side received an iris implant in the right eye, and it matches the other eye very well. So that's what that photo that we send in is of the fellow eye. And so there's some things to think about in the preoperative planning. So the degree of the iris defect and etiology, would any of those other less invasive options work for the patient? It's important to inspect the capsule and the sulcus, see how much zonular support there is, to see how much iris is remaining. The patient's symptoms, so if they're having severe photophobia, blurry vision, symptoms like that, that would be helped with the iris implant. And then very important, the health of the corneal endothelium. With any anterior segment surgery, we are at risk of decompensating the corneal endothelium. So knowing the health of that is important. And then we're kind of examining the eye to think about what is the best placement for this lens. So there's a couple different options. If the patient is phakic and they're getting cataract surgery anyway, the iris implant can go into the bag anterior to the intraocular lens. If they are pseudophakic and there's enough remaining iris there, it could be passively fixated in the sulcus. So basically put into the sulcus, kind of like a sulcus IOL, no sutures required, though some patients could develop with like rubbing on the iris with small movements of the implant. If they're pseudophakic, but they don't have much remaining iris, then it could be put in the sulcus with scleral fixation. And then if they're aphakic, there's no more capsular or zonular support, then of course the implant would have to be sclerally fixated. And then there is an option to implant the iris prosthesis with an intraocular lens sutured onto the prosthesis. And so then those two options, we were talking about the implant with and without fiber. So the fiber is shown here in this picture. So these fibers kind of go through the prosthetic and offer support. So if sutures are needed, any sort of like scleral fixation or IOL fixation to the prosthetic, they recommend using the fiber to prevent cheese wiring and to support the suture. And then this is done intraoperatively, but the sizing of the implant is dependent on like the white to white of the eye. And then in terms of equipment and supply, it's kind of on the left side. It's not totally complete, but it's kind of typical anterior segment tray and whatever you need for cataract surgery if we were placing the implant into the capsular bag. Extra equipment that's kind of specific to this surgery, microsurgical forceps would be helpful. The main wound would be a little bit larger, so closing with tenno nylon. The company also recommends staining the capsule with Trypan blue or ICG, which would enhance visualization of the capsule during implantation. The capsule tension ring should be implanted into the bag as well. Contraction of the capsule can lead to buckling of the iris implant. And then the rest are kind of standard things, the intraocular lens, and then the equipment needed to inject the iris implant into the eye. And then for sulcus fixation, it's very similar, but then we're suturing the prosthetic to the sclera. So the additional equipment we need are scleral marker, vortex or proline sutures for the scleral fixation, Vicryl to close conjunctival peritomy, an MBR blade, the intraocular lens if the patient is aphakic, and then again the equipment needed to implant the iris. And then we additionally use fibrin glue to close the peritomy. These are some pictures of steps of the surgery kind of take place off camera. So a corneal tree fine is used to cut the iris implant to size based on the measurements that are done intraoperatively. And then this is a schematic of fixating the an intraocular lens to the iris prosthesis if that's desired. So if this is done, then you cannot use an injector anymore. You kind of need that really large 9mm scleral tunnel to fold the prosthesis around the lens and then implant that all into the eye. This is a schematic of the kind of setup for the surgery. So there's a 3mm. The main wound is a little bit larger, so 3mm, and then we have kind of variable paracentesis depending on what you need for the surgery. And then there's two peritomies here, oriented 180 degrees away from each other. And then for the scleral fixation, we have two sclerotomies, so on each side here and here, and then a scleral groove between them that's spaced about 4 to 5mm apart. And then how posterior to the limbus it is, about 2mm, but you're kind of basing that on where it looks like the sulcus is. You want to enter at the sulcus. And so in this patient, so a little history about him, 37-year-old patient, he had a history of a shrapnel injury to the eye causing posterior rupture, long complicated history, retinal detachment. He had silicone oil that was then later removed. He's had cataract surgery. He does have a lens in the bag with a capsule tension ring. But you can see from this photo, he has it's like complete aniridia. So this is just a kind of photo of that schematic that I showed earlier with the scleral groove. And then 180 degrees away, there's another. And then we'll watch the video here. I sped it up quite a bit. It's about 4.5 minutes. So here we are making this partial thickness scleral groove that the suture kind of sits in. And then this is the MBR blade used to make the sclerotomies at the end of those grooves. And then here we're making the main wounds. We want about 3 millimeters. And then we're measuring the white to white. And then we're doing sclerally fixated intraocular lens for this patient because he has no residual iris. So sutures are passed through, the Gore-Tex sutures pass through the implant on each side, 180 degrees away from each other. So it's supposed to pass about 2 millimeters long and at least 1 millimeter away from the edge of the implant. And then we're putting this into an injector that's used for IC8 intraocular lenses, so it's a little bit bigger. And then there's a bunch of spaghetti management that happens with these anterior segment cases. So it's going into the eye. This is Dr. Wade. He's trying to save the corneal endothelium. So then the prosthesis is delivered into the eye, and then again, a lot of spaghetti. And then the device unfolds kind of from that posterior direction. So again, to kind of avoid hitting that corneal endothelium. So this is the intraocular forceps. We're externalizing each side of the Gore-Tex suture. And then this is being, the suture is being tied. You want minimal tension on this. If there's too much tension on one side, then the prosthetic would get decentered. And then if there's too much on the other side, then there's some buckling because there's too much tension. And then the Gore-Tex knot has to be buried, otherwise will cause erosion through the conjunctiva. And then here we're closing the sclerotomy sites with tenonylon. And then the groove on this side was a little bit deep, so you'll see later we close it a little bit more. And then we're closing the sclerotomy on the other end of that scleral groove. And then I'm going to skip a little bit here. There's just a little bit of us removing the helon and then suturing the corneal wound shut. So, yeah, we're rotating the knots here. Yes, we'll skip a little bit here. You guys get the general idea of this part. One more. Okay. So here I am closing that scleral groove a little bit more. The other side, it wasn't as deep, so we kind of let it be. And of course, everything's being done twice, you know, on each side of this eye. Okay, and then to close the conjunctival peritomy, in this scenario, we just use fibrin glue, which kind of has two purposes. It keeps the conjunctiva in place, but then also added benefit if there's any small micro holes in the sclera, it'll kind of plug those up. And then we didn't close with vicryl suture, but we probably would close the peritomy with that suture in the future. And then this is the eye at the end of the case. Oh, sorry. Okay, and then I know we don't have too much time left, but these are some slides that Dr. Wade put together about the study that actually got this implant approved for the FDA with FDA. So it's a non-randomized trial. So all patients received this iris implant, 447 eyes, including 44 pediatric patients. And this was done for aniridia and other iris defects. And the endpoints were patient symptoms, especially photosensitivity, their quality of life, and their vision, as well as your monitoring for complications. Contraindications to the implant is kind of the typical things like uncontrolled uveitis, glaucoma, if the eye is too small, and then kind of a variety of other complicating factors that could limit the vision or lead to inflammation. Relative contraindications are very young patients because their eyes are still growing. Corneal endothelial damage. If their other eye has issues or has unknown visual potential, then we'd be a little more cautious of doing the surgery. And an allergy to the components of the lens. And the results were great. So a lot of improvement in symptoms. 63% reporting no or mild daytime light sensitivity, 79% with no or mild glare during the day or at night, and then 94% were satisfied with the cosmesis. Most patients had a gain of one or more lines of their best corrected vision. And then there was no device-related loss of best corrected visual acuity. The main complications were like implant dissociation, increased IOP, iritis synechiae, need for a second surgery to reposition the lens or reposition the prosthesis or remove the prosthesis. CME, this is actually the most common complication. So about 3% of all the patients, 4% of the adults. Everything else was between 1% and 2%. Rarely having retinal detachments, and then corneal edema is more common as well. All right, so thank you so much. I guess the takeaway is if you are, this is new technology that if you do anterior segment surgeries and it's something that you can do. It uses a lot of those same, the same skill set that's used for sutured lenses, for example. And so it's something that can be integrated into your practice. Thank you so much again to the AECP and to Dr. Wade for this opportunity. Are there any questions?
Thank you so much. Fascinating case, nice presentation. In our country, anuridic keratopathy is really very rare. I have only 2 patients, mother and daughter, whom I am following for many years. They both have nystagmus. They both have 360-degree stem cell deficiency, conjunctivalization of the surface. Mainly iris defects we face in our country is due to trauma. And Dr. Vardanyan in our hospital, he does this iris transplant surgeries. I think he uses mainly mortar implants as far as I am aware. I mainly do corneal tattoos whenever the patient agrees, whenever they desire. We mainly do this on blind eyes, but I have had a couple of cases where just they had big, huge iridotomies and they were having this diplopia, and we have done the small, tattooing. It worked well. But of course, there are certain cases where they really need iris implants. And this is really great to see the whole procedure. Thank you for presentation. And maybe with Dr. Matthew Wade, maybe we'll keep a patient for your future visit, and maybe we try to do a case together. I'll see if I have appropriate patients for this procedure.
Yeah, so I'll just, Dr. Chuang, great presentation. I think the most significant downsides to this kind of procedure, in my estimation, really are the cost of this kind of implant, and also the hassle of getting the implant made in the first place. And that's where I think the mortar implants are they kind of shine, because they can be something that you have on the shelf or you order and they're kind of one size fits all. This has some extra benefits, but it's certainly, even for our US patients, is, months and months and months of getting approvals and getting kind of the actual implant made. But I think the interesting thing for me, I think, is where this just points for the future. I think, eventually, hopefully the cost can come down. And right now they hand paint these.
How expensive?
For a cash price is 7,000.
Oh wow, that's a lot for Armenia. 7,000.
Yeah, but I don't know if they have it. I don't know if they have it. That's for a US price, and then they have different prices. And I'm not sure.
Yes, for developing countries.
But that's for hand painted, right? They hand paint that, but in the future they're shifting towards printing them, and that should significantly decrease the cost and hopefully increase the availability worldwide. So something to think about. But very, very great cases that you guys presented. I think your cases are, much above my head in terms of the complications and the difficulties of the things you take care of there. And so it's neat to see that in your experience, and hopefully you learned something from our case presentation as well.
Thank you so much. And I think we got a question from internet. One of the doctors is asking, is it necessary to add beta blockers with dexamethasone if the patient is not steroid responder? Of course, no. We never give any anti-glaucoma med unless the patient is steroid responder. And this patient who is going to leave for Russia, and we are not really sure he will visit in 3 months or 4 or 5. That's why we gave him timolol once a day for prophylactic reasons, because today his eye pressure was it was 19, 20. It was 20 millimeter hydroargyrum, kind of the limit, above limit. So we're concerned he does not develop glaucoma in upcoming months. And as far as we added dexamethasone, and we won't see him for months, so we just felt more comfortable just to give. But otherwise, if the patient is in Armenia, if the patient visits every month and we check the pressure and is not steroid responder, of course, we never give beta blocker. Thank you for the question, whoever gave it. So, Matt, any comments regarding our cases?
I don't have any other comments, but I'm curious to see if there are any other questions from a lot of attendees here today.
Do we have more questions, Tamar?
No.
No other questions?
Yes. Well,
If not,
Everyone
then
wants to go
let's
to bed.
say, thank you everyone for participation, for taking time, for our US colleagues.
Dear colleagues, thank you so much for joining us this late, and I hope that the clinical cases that were presented will be beneficial for the young specialists, and maybe they will be necessary for your everyday practice. So the case of the keratoprosthesis show that you should fight for each eye, even if it's subtrophic and even if the pressure is too low, and you should fight for it. And the experience show that you can preserve some side even in an eye like this. So the quality of life of this patient significantly improved. In regards to the second case, and we were talking about the immune ring, I think that it was another important topic because we were going to perform the PCR of the patient, but on the next day we observed improvement in the eye of a patient because the redness was reduced and even the ring became more transparent. And for the patient, we just recommended only to use artificial drops. We did not let to use any medication. And then we thought that maybe this is toxic immune ring, and probably the patient was receiving more than 20 kind of medication, topical medication. Also, the patient was receiving nonsteroidal drugs, and it showed a toxic effect. So in our everyday practice, it's very important to ask the patient to gather the history to know what's the medication that the patient used. And we forget about the anesthetics, but sometimes it turns out that due to the pain, the patient had to use tetracaine once in a few minutes. And there we go with the diagnosis. I'm very grateful to the Armenian Eye Care Project. I'm grateful to Malayan Ophthalmological Center for being so supportive for this project. And I'm also grateful to our colleagues from the US. We're grateful for our comments. We're grateful to our young specialists, our residents. I'm sure that they presented their cases greatly. And I'm grateful to everyone. And I would like to thank you, Dr. Anna. Thank you for being the chair today. And truly, our meetings will be continuous. And I'm grateful to everyone. And I wish you all good evening. Thank you.